Hello ladies and gentlemen, this is SkullcrusherMD bringing you a new skull crushing educational video. Today's topic is the biceps tendon. This is actually part 2 of our 2-part series on the Biceps Labrum Complex. And this is because I was not able to finish both topics in the first video. Now in honor of this video, we should all do 10 bicep curls as heavy as you can if you have access to a gym, and let's get crushed. Alright, so this is part 2 of our quest to learn about the Biceps Labrum Complex, and this video will be about the long head of the biceps. So the long head of the biceps tendon attaches right here at the supraglenoid notch and the superior labrum. The attachment of the long head of the biceps tendon to the superior glenoid can be described in 4 different types. The first type is where the long head of the biceps tendon attaches completely posterior. The second type is where the fibers are mostly posterior with some anterior, very little. Type 3 is where the biceps is anchored equally anteriorly and posteriorly. And type 4 is where the biceps tendon is mostly attached anteriorly with a little bit posteriorly. Intra-articularly, the long head of the biceps can course in 3 different types. The first one is the mesotendon, and this is when the long head of the biceps is freely movable and unattached to any structure. The second type is the adherent type, and this is when the long head of the biceps is intricately attached to the rotator cuff muscles, usually the supraspinatus. And the third is the split type, where the long head of the biceps has 2 heads that are split and come join into one tendon. The intra-articular portion of the long head of the biceps tendon has a diameter of about 6 millimeters, a length about 9 millimeters, and the tendon can actually slide up to 18 millimeters. The tendon can travel usually about 100 to 140 millimeters up to the musculotendinous junction as it travels through the intertubercular sulcus or groove and under the pec major muscle. The main function of the long head of the biceps is supination. The short head of the biceps is actually the main elbow flexor and also supinates the arm. So when you injure the long head of the biceps, there is usually a weakness in supination. And we recall that supination is the action where your forearm is turned as if you were holding a can of soup. The long head of the biceps receives blood supply from the superior labrum proximally and the anterior humeral circumflex artery, mainly distally. And so there is a watershed region from around 12 to 30 millimeters from the origin and makes the tendon susceptible to rupture. The biceps tendon can be divided into 3 parts. The first part, also known as the inside part, is just the superior labrum and the biceps anchor. The second part, called the junction, includes the intra-articular portion as well as the pulley. The third part, called the bicipital tunnel, includes the tendon extra-articularly and everything onwards. So we need to spend a little time talking about the biceps pulley. Now the biceps pulley is part of the junction, or the second part of the biceps tendon that I had mentioned earlier, and it is integral to the stability of the biceps tendon. Now, if the biceps tendon dislocates or subluxates, it is usually because there is a tear somewhere in the biceps pulley. The biceps pulley is a capsuloligamentus complex that consists of 4 structures. That is the superior glenohumeral ligament, this right here, the coracohumeral ligament, the supraspinatus muscle, and the subscapularis muscle. The left diagram is another way to visualize the biceps pulley. The top here shows the cross-sectional views of the biceps pulley at different locations. And when there is a tear in the biceps pulley, such as the superior glenohumeral ligament right here, you can see that the biceps tendon can displace medially. And with further tears in the subscapularis, this biceps tendon can become grossly unstable and may even dislocate further. I forgot to mention quickly that, as you can see here, when the biceps tendon goes from its intra-articular position to extra-articular position, it actually rotates about 30 to 45 degrees. Now, a biceps pulley tear is clinically significant because it usually doesn't occur on its own. It is usually also associated with rotator cuff tears and slap tears, and it is because a significant rotator cuff tear or slap tear may cause a pulley tear. Thus far, we have discussed extensively about the inside and junctional portion of the biceps tendon. Now it is time to move on to the bicipital tunnel. As I had mentioned, the bicipital tunnel portion of the long head of the biceps is everything that is extra-articular and on. But it can also be divided into 3 zones. Zone 1 goes from the articular margin to the distal margin of the subscapularis tendon. Zone 2 goes from the distal margin of the subscapularis all the way to the proximal margin of the pec major muscle. And zone 3 is everything that is sub-pec. In zone 1, the biceps tendon is stabilized by the transverse humeral ligament, which is really a continuation of the superficial fibers of the subscapularis. In zone 2, the biceps tendon is covered by a thick sheath. And zone 2 is known as no man's land because the biceps tendon cannot be seen via arthroscopy, and the biceps excursion with the pull test does not allow visualization of the entire tendon. Because of this lack of visualization, a third of pathologic conditions of the biceps tendon may be missed in this area. However, it is commonly known that patients with labral tears or junctional tears also usually have hidden tunnel lesions in zone 2. In fact, almost 80% of proximal arthroscopically visualized long head of the bicep tears propagate distally into the bicipital tunnel, and is also accompanied by extensive tenosynovitis, making this a tricky diagnosis considering you can't usually see it, and if there are issues up here, there are also usually issues down here. Additionally, the proximal margin of the pec major is a transition zone from zone 2 and zone 3 of the biceps tunnel, and it can create a bottleneck effect. It can trap loose bodies and debris and anger the biceps tendon by way of creating lesions and synovitis. Eventually, the tendon can hypertrophy and become an hourglass-shaped tendon and look something like this. Zone 3, otherwise known as the subpectoral zone, is clinically relevant because it is the area where many surgeons decide to transpose the biceps tendon. This procedure is called the biceps tenodesis. And what they do is they cut off the biceps tendon at its origin at the superior labrum, and they push it down through the bicipital tunnel, cut some of it, and tack it down right here subpectorally. And with that concludes the anatomy of the biceps tendon in about 7 minutes. There are 3 main points to take away from this lecture. The first is that the biceps tendon is really quite long and that there can be pathology along any part of the biceps tendon. The second is that isolated biceps tendon pathology is really quite rare, and if you see one, you should look for concomitant disease processes, such as rotator cuff tears and slap tears. The third is that if you see lesions or pathology on the biceps tendon proximally, it is likely that there are also lesions and pathology distally, but you often cannot see them because of the no man's land. And that concludes part 2 in our 2-part series on the Biceps Labrum Complex. Thank you very much for watching and tuning in. Please like, subscribe, leave a comment below, and I'll be seeing you in another video. Peace out.